All right, so those going to the Perquimans Lab site, that address is in the chat feature right now. All right, Natasha, I'm sorry if I'm saying that wrong.
Yeah.
Natasha, we were just seeing if there's any questions before we start our lecture today.
Yeah, I do have one. From last Mondays, we were talking about the FISDAP, and on the paperwork, there's 4 different ones that are listed, and there was potentially just 2 that we needed. Has that been clarified before I go getting the wrong stuff, or do we need all 4 of them?
As far as I'm aware, and I think that was covered in the orientation part, you were told that you needed all of them, but just at different times. Like you definitely need the skills tracker scheduler before you start doing the ride times.
Oh, okay. So not by this Thursday. It's something I can get next week.
Well, if you want to count any of your skills that you do in your labs towards skills to check off for FISDAP. Does everybody else have theirs so far?
No.
Yeah, I got the skills tracker.
Okay.
Yeah, I got the skills tracker because there's a link for it, but I'm not entirely sure how to get the scheduler because there's no link for it.
Okay.
I haven't got mine yet, but I plan on going by the building tomorrow and have somebody help me.
Okay. So we need clarification on the scheduler and clarification on the skills tracker.
Well, there's a link for the skills tracker. It's pretty easy to set up. It's just I couldn't figure out how to get the scheduler.
Okay. Were you told to get the tracker now? Is that right?
Yeah, you get the skills tracker now before your lab, and they'll probably put up on that on the COA website the link for when we do need the scheduler.
Right. Okay. Yeah, FISDAP is definitely not my background. I don't know much about it, so I'm learning with y'all on that. But I will definitely just double check on anything for this as far as the scheduler. But I would highly advise you get your tracker. What was that, Callie?
Do you have to pay for the skills tracker?
I believe so.
Yeah, it was I think it was $57.75.
Okay.
Now, I do know we learned if you've ever used it before, once you buy it, you have it. I know I've got to get with John or Walter to reset mine, but I've got to go out and get with John today, so I'll get with him on that.
Correct. So tomorrow, Module 1 test, first lab night. So let's see. Oop.
Would you?
Natasha, what field site are you going for your lab?
Perquimans.
Perquimans. Okay.
But next week it's going to be Elizabeth City. This week is just screwed up.
Okay. So it looks like your Module 1 exam is not until the 11th, and that will be done, I'm pretty sure, prior to when you go to that lab shift, it'll be done before any of the skills. So on the 11th, we have the skills lifting and moving, and then you have that Module 1 exam. I'll probably be prior to that.
Thank you.
Welcome.
Okay.
All right, so we're going to go over Chapter 4. Has everybody had a chance to go over this material and read up on it?
Yes.
Okay.
Yes.
All right, good. So especially when we get into the more in-depth chapters like pathophysiology and going over like A&P and the blood flow of the heart, that stuff is really important to go over prior, because that way, once we log on and go over online, I can answer any questions you have. If it's new information that I'm introducing to you, it might not make sense until you actually go over and read it yourself first. And I have a little cold, so I'm sorry if I'm sniffly. All right, so chapter 4 covers the super fun time of ethical and medical and legal considerations as an AEMT. So some of the key factors when we look at this is the different types of law that you will learn in this chapter. So briefly, what types of law does it discuss, and what do those types of law mean?
Civil and criminal.
Okay. What's the difference between civil and criminal?
Civil, I think you only have to meet like 51% of it to lose your case. Criminal, you have to be beyond a shadow of a doubt that you or criminally did something wrong.
Yep, your book actually defines criminal law as addresses actions that constitute crimes against society, such as homicide, reckless driving, assault, and battery. So reckless driving, we all drive lights and sirens, right? We drive with due regard. What does driving with due regard mean?
Safety of others.
Safety of others, yes, absolutely. Just because you have the lights and sirens doesn't give you the permission to blow through every red light that you come across. You absolutely have to stop at the stop signs and stop at the red lights and make sure that your pathway is clear. So in our job, we have to have a good code of ethics too. So what does your book describe ethics as?
Book describes ethics as a branch of philosophy that tries to answer questions about notions of what is good and bad and what is right and wrong.
Yep. So in our field involving ethics, we have different decision-making capacity features that we utilize in EMS as far as treatment of patients and their consent. So there are different features like implied consent, minor's consent, informed consent, so refusals. So break some of those down for me. We'll start with informed consent. What to you does informed consent mean?
And you tell them what you're going to do and they agree that you can do it.
Okay. Yep. So these people are willing to accept treatment. Absolutely. So how about express consent?
I think the example the book gave on that one is you say, like, I'm going to take your blood pressure now, and they just kind of stick out their arm. You don't really tell them why you're taking their blood pressure.
Right. Right. Yep. And, you know, it's not a verbal agreement. Like you said, they kind of just like reach their arm out, you know, so they're expressing to you that that's okay. How about refusal of consent?
That means they don't want you touching them.
Okay. So what are some issues that we can get into if a patient refuses any type of treatment, but we still try to render care? What kind of legal issues could we fall under with that?
Assault and battery.
Absolutely, assault and battery. So refusals can get kind of difficult. It depends, were they the ones who actually called 911? Was this a second party caller, third party caller, fourth party caller? So going beyond of just who called 911 can make a big difference. Is this a no patient found situation, or is this a refusal? So when would I choose the difference between those two scenarios?
Well, for instance, if someone else called 911, they have, I mean, every right to refuse because they didn't call for the help.
We see it a lot in MVCs where people drive by, maybe they see a car that has slid into a ditch. So these are fourth party callers. They don't stay on scene. They call as they're on their way going through. You get there and the patient's like, well, I didn't call 911. I don't need EMS. You know, so that's typically more of our no patients found because they're not the ones who actually requested any 911 assistance. So knowing the difference between, you know, the refusals and the no patients found is definitely important. Because with no patients found, we typically don't have to get a signature, but with refusals, you do. So we also get into advanced directives that we see in the field. So what are some advanced directives that you will see?
DNR.
Okay, so what is a DNR, Brian?
It's a do not resuscitate order.
Okay.
And you can still perform life-saving skills, but you cannot perform CPR on them, pretty much.
So how do we know a DNR is valid?
Has to be signed and dated.
Signed and dated, okay. Can these be copies?
No,
No, it has to be original.
Absolutely, it has to be the original form. A lot of nursing home staffs, if you go there, typically they'll give you a copy of the DNR. That is not valid. You have to have that original yellow with ticket with the golden stop or with the red stop sign with the doctor's signature, and there should be a valid date and what it's valid through. So those are very important to know. Part of DNRs is educations with your patients. Sometimes if you go to their house and they have like their file full of last hospital admissions and you're digging through to look for their history and their medication intake, and boom, what do you find? A DNR. So letting them know that, you know, things like this are not valid unless they are posted and we can see them and actually physically have them in our hand. You know, they're something that they would like to be honored, then we need to make sure that we are able to find and locate these items. So we have a DNR. What's another form that we have, but it has a little bit more, I like how Cliff pointed this out last night. It's more of an a la carte menu, and you get to choose your treatments, what you do and do not want to happen to you.
Living will.
Okay, living will. There's a more specific one.
Physician's order.
Is it the POLST?
How about a most form? There are different names for it now. It used to be called the most form, and you can actually go to the North Carolina OEMS website and they have a picture of your DNR form and your most form. The most form is typically like that pink, fuchsia, purpley color, and actually has check marks in there of what they are willing to receive and what they do not want to happen in case they go into cardiac arrest. It's more long-term care of the after effects of any treatment. So yeah, the most form, I would definitely go online and look at that. Can a family, if you go on scene to a cardiac arrest and there is a valid DNR present, can the family say, no, we want to null and void that. I want you to work on my loved one?
No.
Nope.
No.
They can. The family can. It has to be a direct family member or a health care power of attorney. I know a lot of times we go on scene and people are like, well, I'm the power of attorney. It doesn't matter. They have to be a health care power of attorney, and they have to be able to provide documentation. That goes more broad spectrum of any health care, any transports we do. But yes, if you go on scene, that family can say that we do not want to honor that DNR. And if you actually go to the OEMS website and look at their policies and procedures, it's in their outline. It's kind of buried. And I'll try to find that too for you. But those are sticky situations because most of the time their emotions come into play at this point. And you know, their loved one, something happened to them and this wasn't expected maybe, and they're not aware of what's going on. They're kind of in that fight or flight response, and they're just saying, do whatever you can to save them. So remember, we have to be empathetic in these positions, and we have to try to educate them in the right way to let them know, you know, especially if they're beyond any help. But they are definitely sticky situations, and they're not fun. So as far as making medical decisions, refusals, and things like that, what are some other factors that come into play that we've noticed on scene with patients?
If they're competent,
Yes. So what does that mean?
they're aware of the situation and they know like who they are, what date it is, stuff like that.
Yep. So these could be our altered mental status patients, our hypoglycemics patients. What other patients would you think that would have an altered level of consciousness? What medical history?
Stroke.
Stroke?
Certain mental disorders like dementia.
Yes. Mm-hmm.
Alcoholics.
Alcoholics, okay. All right, so how about age? Does age come into play?
Yeah, if certain patients are too young, they can't consent to anything.
Okay, so what's the age?
18.
18. All right, are there special cases to where somebody under the age of 18 can refuse care?
They're
I'm not sure about
emancipated.
refusal of care, but I know that there's implied consent in certain situations.
How about if they're emancipated?
Emancipated, yep. So emancipation is a legal document that the judge has granted this child or individual in order that they can separate all legal ties from their parents and that they are taking care of their own well-being. So yes, emancipated minors is something that we've learned about. We learned about it in basic class, but honestly, how many of us have encountered an emancipated minor? Because I haven't in my 13 years. So there are definitely more cases, and I feel like I learn about them more on calls of when patients can refuse care. And some of them kind of tip the scales of, is this legal or not? So there is talk about if that person has a child. So if they are 16 or 17 and they are a parent, are they able to refuse medical care?
Yes.
Does anybody else have any other insight?
I would call the supervisor.
I'm trying to find in the book what it says exactly. So look in your book under emancipated minors and see what it actually, or it should be under that same section. And the reason why is because there are two different thought processes on this. One is, yes, since they are a parent, that they are able to refuse any medical care for themselves without having their parent or guardian sign. And then there is another thought process that they are not able to refuse care for themselves, but their child.
Where's that in that book, Caitlin?
That's what I'm looking for.
It says right here, minors who may be emancipated include those who are legally married or in the military, and may also include minors who are parents.
Okay, so there we go. Your book says minors who may be parents. I know that was one thing that we had a discussion about last week in another class, and some had heard that it was one way and some had heard it was another way. So does everybody understand that it's minors that may be parents?
Yes.
All right, so we were talking earlier about civil claims. And one of the main civil claims that we hear about in EMS is negligence or breach of duty. What are some other cases of negligence or of civil cases that you can think of in EMS?
Abandonment.
Given the wrong medication.
Breach of confidentiality.
I think breach of confidentiality is a big point because that spans into like defamation of character, goes into slander and libel. So what's the main difference between slander and libel?
Slander spoken, libels written.
Okay. And then, of course, we get into, like we just said, the medication errors. Those are more of our high-risk situations. So what is that nifty tool that we use before we give any medication to make sure that we are doing everything properly?
Protocol book?
Yeah. But what do we verify? Right person.
Right person, right time. That thing?
Yes.
Right dose?
Mhm.
Right drug? Anybody else can jump in here at any time.
Right patient, right medication, right dose, right time, correct route.
Documentation. Yeah. All right, so we move from our civil claims to our criminal issues. So what are some, I wouldn't say cases, but what are some things as an EMS provider that we could be held criminally?
Kidnapping.
So what is kidnapping in EMS?
Taking somebody without their consent.
Uh-huh. So what patients could fall under that?
Any of them.
Any of them. How many times have you gone to a nursing home and Miss Grandma has fallen, and the nursing home is like, well, you're taking this patient because our protocols state any fall patients we have to send out. But Miss Grandma's like, I'm fine. I don't want to go to the hospital. Alert and oriented and able to make her own decisions. Well, they go, well, Miss Grandma's healthcare power of attorney is on the phone. What do you do?
I think you have to decide with the power of attorney. Because if grandma was actually in her sound mind, then she wouldn't have a healthcare power of attorney to begin with.
Not necessarily.
How do we know for sure that's her power of attorney if she's on the phone? We don't have any paperwork.
Yep. If grandma doesn't want to go, grandma doesn't have to go. That's something that if, you know, it's one of those situations, and I know we've all been it before going to an assisted living facility or whatnot, and one patient does not want to be transported, but the healthcare workers think that they should be. So that's where we tie in education as well. Sometimes talking to the patient, well, why don't we just go ahead and it won't hurt to go and let's get checked out. I mean, it stinks that we feel like we have to persuade them, but technically if that patient does not want to go and they are in the right frame of mind, that can be kidnapping. And I tell them that. I tell the workers that. I'm like, do you understand what kidnapping is?
I do too.
And like I said, sometimes just that education goes a long way, because like I said, their policy and procedures are different than ours. So what does HIPAA play in with criminal law? Or how does HIPAA play in?
Identity theft?
How does HIPAA play in the EMS field? So what is our duty to protect HIPAA?
Their
Why is-
privacy.
Okay,
You can face criminal charges for breaking HIPAA law, right?
absolutely. So what are some ways that we
Yeah.
could break HIPAA law?
Talking about the patient and their illnesses with people that were not on the call
Okay,
and that didn't have
Anybody not on the
patient
call or
contact.
involved in the review process?
okay. So you said the billing process?
Billing, quality review. Other than that, it's all restricted to anything that can identify that patient.
I know we frequently get family members phone calls that come in to the station and they ask for copies of so-and-so's care report. Doesn't matter who you are, you have to fill a form out and get a signature from the person that the PCR is on to make sure that we have consent to release those medical records, because that's what they are at this point, they're medical records. So there's a whole process to cover COIA to make sure that we are not breaking any of these HIPAA laws. But yes, sharing any patient information, Facebook, social media, anything is a no-no. Please do not post pictures of you on the back of the ambulance on the way to the hospital with your patient's toes or shoes showing. That can be a form of HIPAA. So just make sure that you are just covering yourself and no social media in the back of the truck. Just read over our legal protections and just make sure you scan over the Good Samaritan laws, your governmental immunities, and the statute of limitations. All right, so crime scenes. What is our responsibilities as EMS providers at crime scenes?
Our safety.
Okay, absolutely, our safety.
Try to preserve evidence, like take the same trail in you did, go out and in the same way.
Okay.
Limit your personnel on scene as best as possible and avoid, removal of cutting, obvious cutting through bullet holes in clothing or stab.
Okay. Yep, I think the most important thing is, of course, your safety and recognizing that crime scene. So if you go there and you see somebody who has been shot, sometimes you might not know it until you actually do your assessment on this patient. So just looking at your clues and your scene and making sure that you do not disturb any evidence.
And if you move anything, you need to tell law enforcement you moved it,
Yeah.
especially the weapon or anything like that.
So going right back up to legal protections, I skipped over documentation. So I really want a lot of discussion in this area because documentation from a QA/QI standpoint is very important, and I feel like you can never put enough information into your patient care report because, like I said in last class, these aren't going to get pulled tomorrow. They're going to get pulled 5 years down the road if they go to court. So you need to pack these full of information, descriptors, quotations, anything the patient said, you put into quotes. So there are some specifics that I want you to point out in that documentation part. It's under legal protections under page 71. It's that last paragraph, and then it goes over to page 72.
Complete the documentation as soon as possible.
Okay.
Be professional in your documentation.
Don't give your own opinion, give the facts.
Absolutely.
No, like it says in here, it says don't put the patient was drunk. Instead, put that the patient said they had X amount of drinks between this time, and what the drinks were.
I think that's a really big one. We encounter patients that have the smell of ETOH, and that's why a lot of documentation programs have drop-down boxes now, and you'll see like patient admits to use, or patient has the smell or odor of ETOH. If you put that the patient was drunk, you are putting your objective into that PCR. You don't have lab values, you don't have a breathalyzer, so you cannot say that that patient is drunk. But you can absolutely put in quotations that the patient said that I had 2 beers. Or you can say that you did have, that there was the odor of ETOH was present. So just make sure that when we're wording things, we're wording them that they don't come back and bite us. Because if they see that in your report, and it goes to court, that's what they're going to focus on. Not that you started the IV and stopped their arterial bleed. It's going to be, well, did you not do something because you said your patient was drunk? So just make sure that we are not backing ourselves into a corner. A lot of places have gone to e-PCRs, so they're electronic PCRs, but for any paper documentation, remember the old school way of, if we make an error and we're writing in pen, just to mark through that error and initial it. Don't go and try to scribble everything out. All right, so that is it for chapter 4. Does anybody have any questions for chapter 4? All right, so we're going to go to chapter 5. Chapter 5 is the ambulance operations and responding to EMS calls. I think maybe next week is when we start getting more into the AEMT specifics. Oh, excuse me. All right, so phases of an EMS call. Can you guess how many phases there are to an EMS call?
6.
Okay, so what is the first one? And then tell me what it is.
Preparation. That means having your body and your equipment and your truck ready to go.
All right, so somebody, what's the second phase?
Receiving and responding. The just actual receiving of the call, responding to the call, pretty much everything prior to contact with the patient.
All right, so does everybody's agency has a time from when the tones drop to when they're out the door?
Yes.
Yeah, our shoot time.
And what is everybody's 90 seconds?
Yes.
All right, so what's the third phase?
On-scene care.
On-scene care and preparation for transport. All right, the next phase.
Transporting the patient.
Transporting the patient.
And then we have two more.
Transferring care.
And terminating the call.
Okay. So when we are getting our initial dispatch, so we're receiving and responding, what do we do with that information? When dispatch advises us of the call, what are we doing when we are receiving that information?
You can start your primary assessment.
Okay. So what two categories do we typically try to place those into when we're on the way to the call, when we receive that information?
Medical or trauma?
Yep, medical or trauma. So why is that good to know? I mean, what are we going to do with that information?
Start making a treatment plan.
Okay. So what are some of the biggest differences between our mindset for a medical call and our mindset for a trauma call?
So you're going to gear your entire mindset differently. Medical calls are probably, you're not going to see a lot of blood or bowels or anything twisted around people's bodies that's not should be there.
Okay.
You can also determine if you need extra resources.
Exactly. I think maybe that's one of the biggest things is additional resources. So of course we can have a medical call that's a STEMI or stroke that maybe we need to get to a different facility. But trauma patients, absolutely. We don't know factors as things as, you know, spills, fluid leaks, smoke. So is this patient entrapped, pinned in? Is the vehicle not accessible? So there's different factors that we would need to know for these traumatic injuries and what they are. So yes, additional resources. Is everybody familiar with MCIs? Mass catastrophic incidences? And does everybody utilize the ICS system on MCIs?
Yes.
MCIs and triage is not covered much in this section. They just glance over it because it's in the operation models. I believe once we get further into the book, and it's probably in the back of the book, is when they typically expand more into it. All right, so then we jump to ambulance design. So what are the three different types?
Class 1, Class 2, Class 3.
Okay. So what is a class, what is a type 1?
Type 1 is a truck chassis with the truck cab still attached and a box put on the back of it.
All right, type 2.
A van with the roof chopped off, modified with more fiberglass so you can actually stand up.
And the type 3.
You want me to keep going?
Sure.
Okay. It's a heavy modified van chassis that still has the cab intact that you can walk back and forth from the cab to the box. And it has the box attached, unlike the type 1 where you only get like a little small like doggy window to talk to your
Right. It goes into your vehicle readiness, your emergency vehicle operations as far as your lights, your brakes, tires, windshield wipers. These are all things that everybody should be familiar with. They should be on your truck checkoff. Go into defensive driving. Everybody's taken a CEVO, EVOT course.
Yep.
Yep.
So when driving an ambulance, so what to you, and we'll each answer one, what to you is a big difference between driving our personal vehicles and driving an ambulance?
The size.
The size, okay? Yeah. There's nothing more
Center of
fun than
gravity.
driving in Elizabeth City down the tiny roads in a big ambulance, right?
Center of gravity, we all know when you're in the back, it's not as stable as far as the effect when you go into curves and stuff and how that affects your personnel in the rear of the box.
Yep. They go around that curve and they hit the gas, and then next thing you know, you're in the wall.
Yeah.
So we have our size, our center of gravity. What are some more factors that are different?
The handling.
Yeah.
Yep, I think one of the big differences is like our turn radius is different. When you're turning onto another street, you have to make sure you kind of come out and go in. So yes, handling. How about our stopping factors? They don't stop on a dime like a car does. How about safe backing? Does anybody have any policies and procedures in place at their agencies for safe backing?
Oh, do we?
Come on, y'all, I need conversation.
Oh, I'm not real sure because we just kind of wing it right on into the bay.
I
know
don't
the
know
book
if
said to
it
have a
has
spotter.
Yeah, you need to have a spotter.
Yeah, a lot of agencies actually have it in their SOGs that you have to have a spotter. Now, whether you go by that is a different story. But yes, actually they have, a lot of places have SOGs where it's mandatory to have that backer and backing you up because of course they are bigger and they have a lot of blind spots. And a lot of people like to come where? Right up on your bumper to where you don't even see a vehicle. And then they highlight highway driving, night driving, and then of course driving with lights and sirens. Driving with lights and sirens is a different animal. I know, especially when you're new in EMS and you get that blood pumping because you've got lights and sirens going and you're thinking that people are going to get out your way, but what happens? They don't. They don't, right? What do? You're in the left lane like you're supposed to and you're chugging along and you're going lights and sirens and people look at you like you're an alien and then they want to stop right in the highway, which causes you at that point, your braking radius, your stopping distance has already been shortened and now they want to stop and right in front of you. So yes, lights and sirens is a different animal. Just go over what to do at intersections. All right, so you're responding to a motor vehicle accident on a highway. How would you secure that scene when you are the first unit on scene? You've beat fire department and you've beat highway patrol.
Park behind the accident.
Okay.
With your lights and stuff on.
All right. So when somebody else arrives on scene, do you move?
Yeah, you move up to the
No.
front.
No.
I would let incident command make that decision.
I like that answer. Your book says yes to move to the front of the accident. That way, if there's two different agencies or two agencies on scene, that accident is secured from the back and the front at that point. And that way there's prior notification too, if you have your lights and sirens on when people are approaching the scene, that they just don't see it last minute. So what are some things that we can make sure that we stay protected ourselves while we are working an accident on a roadway?
Make sure the tires are turned away from the scene and you got reflective vests on.
That is a big one, because how many of us go on scene and actually think about turning our wheels the opposite way? I never did until I've read it. Honestly, it's just something that I never thought of. So Brian, just for kicks and giggles, why would you turn your wheels the opposite way?
If your ambulance gets hit from the rear end, it's going to follow the way that your wheels are turned. So if you turn them towards the scene, you're probably going to get smashed by your own ambulance. If you turn them away, then the ambulance is liable to go in the median or the ditch or another car besides you.
Right. Yep. So I think little key factors like that sometimes can make the world of difference at the end of the day. So just make sure you turn your wheels opposite of where the scene is. So what was the other thing that was mentioned?
High visibility vests.
Yes. Okay, so we go to that accident on the highway. What are some factors that come into play that can limit our care or limit our scene safety?
Are there traffic on the highway?
How many lanes of traffic there are?
Yes, absolutely.
If the person in the vehicle is entrapped or not?
Yep. So our mechanism of injury is important. Our location is important. How about the weather factors of that location?
I
Are
would
we
say so.
equipped?
Is it gonna
Are
be
we
slick?
equipped to deal with snow here, really?
No.
How about number of patients? Is that a factor of how we render care?
Yep. And if they speak the English or not.
If they speak the English or not. So the things that we just list, what are those typically called? When do we do that?
Scene size up.
Our scene size up. And when does your scene size up begin?
When you arrive on scene.
So there are definitely different takes. Your scene size up can absolutely begin upon dispatch. When they say you've got a single car NVC, one vehicle or single occupant, cars upside down, what is your scene size up already saying to you?
Car's upside down, somebody's in the car.
And you need what?
I'm going to need fire, possibly a helicopter.
Okay. So when you arrive on scene, before you even exit out of your ambulance, what are you doing?
Looking for what they're telling me that I should be looking for.
Okay. So you're doing your windshield survey. And so our windshield survey, when we arrive on scene, we're looking for factors that we can answer. Is our scene safe? Do I need additional resources? How many patients do I have? Things like that. And of course, the mechanism of injury is typically forefront if we see a vehicle upside down. Is everybody familiar-ish with lifting and moving patients? The proper lifting techniques, our power grips, our power lifts. Is everybody familiar with these terms?
Yep. Thumbs up, use your leg.
Yes.
Just make sure you go over those prior to the lab. I feel like even if I talk to you about it, it's just something that you're going to have to read. And most of us know how to do them anyways. It's just putting the name to the thing that we do. All right, so our positions are super important for especially documentation in our PCRs. So what is Fowler's position?
Sitting more than 45-degree angle
On what?
on the stretcher.
Corrector.
How about semi-Fowler's?
Less than 45, but more than, I think, like 15 or something.
Between 30 and 45.
Yeah, there you go, Keely.
So what do those mean? Like, are we actually getting a ruler and measuring how far in degrees our patient's head is elevated?
No, it's either pretty much going to be straight up or you're going to be kind of lean back. One of the two. Or you're going to be laid flat.
Absolutely. So when would we choose to put a patient, like what medical condition would we simply take them from semi-Fowler's and put them in Fowler's?
Breathing.
Breathing difficulty. Yep. Okay. So what about our unresponsive patients? What recovery position do we typically put them in, or what position?
Recovery position.
Yeah.
Or left lateral recumbent position.
Okay. And so what is our goal with this left lateral recumbent position?
Keep their airway open.
Keep their airway open. So what kind of patients would we utilize this for?
Unconscious.
Unconscious. Okay.
What about seizure patients?
Seizure patients. Absolutely.
Somebody with abdominal discomfort.
Okay. And I also think of our, I guess still unresponsive, but patients who are vomiting and they can't control their own airway, or they can, but we don't want them to aspirate that vomit, that we will put them on their side.
Pregnant chicks too.
Pregnant chicks.
Yeah.
So why do we want to put pregnant chicks on their left side?
Blood pressure.
So the weight of their belly doesn't mash down on their inferior vena cava. Straight out of the book.
That is good stuff.
Pretty much so you don't suffocate them.
We don't want to cause a drop in their blood pressure, right? And their heart rate. So everybody should be familiar with types of equipment that we utilize. So we have stretchers. I believe all of us have been blessed with automatic stretchers. And even some of us have the power load systems. I mean, how great are those? They're awesome. But so manual stretchers still exist. People still have to use them. What about backboards? What are some different types of backboards that we utilize?
You got a scoop stretcher.
Scoop stretcher, what are those good for?
Scooping somebody up out of the ditch.
Yeah, so people in tight places, maybe?
People with broke hips.
Yeah. Back in the day when we had to backboard and C-collar every single patient, it was really good with those geriatrics with kyphosis. So they had that curvature of the spine, that little dip in the scoop stretcher. You could actually put a pillow underneath their back. And so it would, you know, comfort them a little bit more, because that had to hurt. It was definitely uncomfortable for them. All right, how about stair chairs? Your departments utilize stair chairs? Does everybody have the nice rail system where you just slide down the stairs? They are really, really nice. They are back savers. We use them all the time, and I highly encourage people to use them all the time. It does brief on specialty stretchers as far as your bariatric and your neonate. I think just reading up on specifically what those are. So what's the bariatric stretcher?
It can lift over 700 pounds.
And neonates, we know, are for babies. Go over your different types of drags. There's the armpit forearm drag, the shirt drag, the blanket drag, the extremity lift, and then there's different ways to carry, the direct ground lift, the direct carry. I think one of the most important ones, because this is the one I see in EMS that we utilize the most, is the draw sheet method. You want to make sure that anytime you're moving a patient from one bed or one surface to another, that we are not reaching and pulling. You need to make sure that that patient is brought into your area. Bring them to your center of gravity before moving them over. So reach injuries are one of the leading causes of back injuries or back strains. And that's something that we're definitely going to go over in the lab. Does everybody have the chance to utilize any air medical transports for 911 calls?
I've got to call them.
Got to call them?
Seeing them on scene.
See them on scene?
I've had them come into the back of the truck and help intubate a patient.
Yeah, absolutely. I've had them try to decompress a patient before in the back. Yeah, they are great and they are useful. Do we know the ins and outs of when they are needed, for what calls are they are needed, their specific landing zone setups? I mean, are you anybody familiar with those?
Yes.
Major trauma. You know, something that Albemarle can't put a Band-Aid on, they're probably going to have to get flown.
Okay.
STEMIs are going to get flown.
STEMIs. Usually when we have to set up the landing zone, we are usually able to rely on our fire department for that, or the hospital if they already have a landing zone available. But your book does specify that the landing zone needs to be a large flat area free of obstacles and hazards and at least 150 feet from the scene. So what is our goal size for our landing zone?
100 feet by 100 feet.
Yep. I think one of the most important things that we forget is if we are flying somebody out at night is to make sure to turn off all of your lights, turn off your emergency lights, because they utilize the night vision. I don't know if there's a special word for it.
NVG.
Thank you. They utilize that, and so your lights could
Blind.
not be helpful. Yes. Go over your approach area for your helicopters. If you ever get the chance to help them hot load, I definitely encourage it because it's really fun and it's different. All right, so that is it for chapter 5. Does anybody have any questions?
Now they still utilize the old manual stretchers, correct?
They do. Mm-hmm.
To cut down on the weight?
Yep.
Yes. I believe they said that the difference between the manual stretcher and the automatic stretcher is about like 40 pounds. 40 pounds heavier for an automatic stretcher.
That's a lot in the back of a helicopter.
All right, so we're going to go into chapter 6, communication and teamwork. I actually feel like we covered most of this already. It's documentation, the incorrect and correct verbiage to use, but we'll go over some of it. It's a lot of radios as far as repeaters and sites and the proper communication on how to speak on the radio and the radio communication guidelines. So I think a lot of that is more work that you just need to glance over. But I think there's some main parts that we can cover. So team dynamics and communication. Why is it important to have good communication in a team setting?
More organized.
You and your partner both need to know what you're doing.
Yeah. Yep. So we all have the common goal of providing safe and effective treatment for the patient. So we need to make sure that we have that one person. I wouldn't say that's responsible for it all, but that one patient or one person who is the lead and is able to have a sight of knowing what's going on in the full picture. And then you can delegate those duties. So of course we always look at, cardiac arrest as one of the great team dynamics and one of our leadership communication tools that are very important. So you have that one leader who can sit back and have their clipboard and go over and look at everything while everybody else there's an airway lead, there's medication lead, there's an IV lead, things like that. Somebody doing CPR, somebody giving ventilations. And that initial team lead is able to step back and watch the whole thing and able to make sure, okay, it's been 3 minutes, make sure and tell the person administer medications to go ahead and, give another dose of epi. So team lead and communication is very important in EMS. Who can be a team lead?
Anyone with proper knowledge.
Absolutely. Anybody. It doesn't have to be the paramedic on scene. It could be anybody, because what if you're the only paramedic on scene and that patient needs a paramedic skill? Well, sorry, you're not team lead anymore. Yes, anybody that has the knowledge of the agency protocols can absolutely be the team lead for that call. It specifically states this for communication, so I'm just going to read it, that the Federal Communications Commission, the FCC, is responsible for oversight of many different types of communication systems, including EMS radio communication. Maybe that's just a fun fact. So radio frequencies and traffic. So for your department, what do you utilize? Are you always on one channel, or are you told to a channel to go to, maybe a TAC channel or something, depending on the call?
For Quims, it depends on the call.
Okay.
In Chowan, we're always on one channel.
One channel.
Currituck's basic EMS calls all stay on the primary.
Are you VHF or 800?
We're 800. Any working incident tied in with the fire department's vehicle accidents or anything beyond that, they'll move to a operations channel. But standard EMS runs all stay on the primary.
So if you have to set up an incident command system, let's say your fire chief is incident command, how do you communicate or hear orders from him? Are they relayed to you, or you go to that channel?
No, if we're going to something bigger, we'll switch to whatever the TAC channel is. TAC channels are preset by each fire district.
Okay.
could be 4 Battalion 10, 4 Battalion 10, 110 White Heron Drive, 110 White Heron Drive. Reference to 80-year-old male.
All right, so trust and rapport. Why is it important to build up trust and rapport with your patient?
If they don't trust you, they're probably not going to ride anywhere with you.
Don't get in the car with strangers, right?
So you can get correct information about their present illness, history, what's going on.
How many times have you been to a patient and you've asked them for their medical history and their medications they take, and they go, oh, nothing. And then you go to give them a medication. They're like, oh, I can't have that. I'm allergic, or I can't have that because I take this medication, or I have diabetes, or I take this because I have diabetes, but I have no medical history. Does that happen to anybody?
Yeah.
Yeah.
Yeah,
Yeah.
happens a lot. So yes, building up that trust and rapport. So when we go to patients, they're not always in their best, because if they are, they wouldn't be calling 911, right? So they may already be emotional or stressed or in pain. So we're already dealing with somebody that's not at their normal. So yes, going in there and building a trust and rapport is important. So how are some ways that we as EMS in our 10-minute encounter with these patients, how can we quickly build up a trust and rapport with them?
Get on their level, look them in the eyes, treat them with respect. Don't give a
Introduce
resting
yourself.
bitch face.
Show empathy.
Yes. I know we're in the South and we like to call people sweetheart, hun, dear, but EMS is not the time or place to do that. They can call us Shug if they want to, but let's not return the favor. Let's keep it formal. So in EMS, we need to remember our non-verbal communication. What is our non-verbal communication?
Your
RBF.
body language.
Nod their head, yes. Nod their head, no.
Facial expressions are huge. I'm not going to say the term, but resting.
RBF.
I know we know that term. How many of us are in a situation where we're hearing somebody and we're processing that information? We might not be saying something, but our face definitely is. So yes, let's make sure that when we go to grandma who stubbed her toe at 2 in the morning, that even though we're saying nice things, that our face is presenting nice things as well.
It's those regular dialysis patients that get me.
Yeah. Yeah. I'm gonna tell you, like I keep telling everybody, just because it doesn't seem like an emergency to you, it might be an emergency to them. That call you go to grandma at 2 a.m. for the stubbed toe might not really be a stubbed toe. She might not have had supper for the last 4 nights. She might not have any heat, but you remember those older generations, they're proud people. They're not gonna want to admit things like this. So sometimes there are other factors that are going on. So us being empathetic, us being that trusting ear and showing them that we care goes a long way. We want to make sure that we practice active listening, not doing our patient report here. Yeah, I hear you. You know, make sure that we are doing active listening. Communicate back with your patient when they're talking to you. So when we ask questions, we want to ask open-ended questions. So what are some open-ended questions that we can ask our patients?
Ask them,
Can I
what
help
does
you
the
today?
pain feel
How
like?
are you feeling today?
All right, so I heard, what does the pain feel like? What was the other one?
How can I help you today?
You're reading straight from the book. Y'all hear that?
Still coming in real static and broken off.
I think that's Keith's call. Let's see. Well, I guess he is on the way to a call. All right. So yes, Asking open-ended questions are important because what do?
They give you a lot of information about everything and anything in their laundry basket.
Yeah, they lead to more things that we are trying to discover. So at this point, we have our detective hats on and we're trying to find out either what the source is or what the cause is, which is the same thing, source and cause. But typically this is more of our like our OPQRST and our samples. You know, we're trying to discern what is going on with this patient. So if I ask the patient, do you hurt? And they say yes, is that an open-ended question?
No, it's closed-ended.
Closed. So if I ask, can you describe the pain to me? And they tell me, oh, it's here and it moves to my arm and it's a pressure feeling. So I go from pain to now I'm thinking, what kind of pain is this? Cardiac. You probably can't see me.
Say chest pain?
Chest pain. Yep. So yes, open-ended questions are definitely important. Then it breaks it down into clarifying, confronting, facilitating, reflecting, silence, and summarizing. We went over documentation and what a patient care report is and, you know, what we should do to best utilize that we are doing the best we can at documenting those. A lot of agencies have where your partner who is on the call with you has to sign that report as well. What are the practices as that second provider that you are doing when you sign that report?
You're supposed to be proofreading that report.
Why?
So it doesn't make you sound stupid or your partner sound stupid.
So if I go onto a call with Brian and Brian does the care report and he doesn't write anything. He says, we came, we saw, we left. And I sign that report. If that report goes to court, can I be held legally responsible as well for the documentation in that report?
You can. High fives around everywhere.
Do what?
High fives everywhere. You're coming with me.
Yes, absolutely. You can be held responsible as well. So make sure that if you are signing that report, that you are doing yourself proper justice and reading over that report. It goes into, I call these old school ways because typically this is how you see older people in EMS who have been in EMS a while document their reports when they're doing the PCRs. They have like the chart. It's the chief complaint, the history, assessment, treatment, and transport. That's a chart method. Does anybody actually utilize that? I know I see people do it when I do QA. Then they have the SOAP. I've never used the SOAP. And then they have the cheated. So those are all on page 122 of your book. Maybe they could help you in your documentation. So on page 123, it goes over a refusal, and this is just a sample of one that they provide, but refusals are very important. If it asks for the patient signature, get them to sign. If it asks for a witness, get a witness to sign. Usually get another family member, or if law is on scene or somebody else other than you or the provider, get them to sign as a witness because you kind of have that backup as well. If it has a date, put a date. If it has any directives that you're leaving for that patient, like follow up with your doctor or call 911 back if symptoms return, make sure that you are documenting these things because those are legal forms. Well, that is it for chapter 6. That was actually a very short chapter. So we have some time to burn. What are some questions that you have on anything we've done so far, about lab sites, anything that's required, and what questions do you have?
Ooh.
I have a question, but it has nothing to do with lab sites. On page 69, can you pronounce those M words for me?
Probably not. Oh, yes, that's a good one. So malfeasance, misfeasance, and nonfeasance. So that's a good one to go over. So page 69 in your book. There's also a table at the bottom. So your book, what is malfeasance? What does your book say that malfeasance is?
Performance of an improper act.
Okay, so what's the example?
An advanced EMT performs a skill that is not within his scope of practice, or performs a skill that is within his scope of practice but not, was it indicated for the patient?
Yep.
For example, inserting an advanced airway into a patient with a gag reflex causing vomiting and aspirations of stomach contents.
Okay, so malfeasance is if the AEMT does something outside of their scope of practice. So if the AEMT pushes a medication that they're not supposed to, so let's say a narcotic, you can be held malfeasance. And then also if you do something that could cause harm to the patient, as far as, like, they give the example of putting an OPA in without checking a gag reflex, which causes the patient to aspirate. That's malfeasance. So what's misfeasance?
The improper performance of a legitimate act. An example it gives is an advanced EMT is caring for a patient who needs an IV intravenous dextrose but fails to recognize that the IV is infiltrated. He administers the dextrose, which enters the tissue and causes tissue damage.
The misfeasance, that can happen a lot, right? How many times do we give an IV, or have you seen an IV given and it's blown and they're still trying to pump fluid into it? I've seen it a lot.
I've seen it. But I've seen it also been painting, and then all of a sudden, for some odd reason, it blows. And
Right. Yeah. There's things that we're not doing to harm the patient, but it just happens. We have factors like, are they geriatric? Are they obese? Are they cancer patients? Do their veins just suck? There's different things that come into play that are beyond our control. But trying to notice these factors and seeing that is infiltrated, has our IV bag stopped dripping? Usually if it stopped dripping, it's because there's either no more space for that fluid to go into, or there's some type of obstruction. So just try to notice those signs and symptoms. Typically, if it's infiltrated, if you feel it, it could be cool, it could be tough, there could be some swelling going on. So just looking out for those to make sure that you are not being held for misfeasance is important. All right, so what's nonfeasance?
failure to perform an act that should be performed. Says an AEMT should apply an automatic defibrillator to patients in cardiac arrest, but fails to do so.
So what does that also sound like?
Negligence.
Negligence. So you have your duty to act. You were called, you were needed. You have your standard of care, you know what to do. But then you failed to put that defibrillator on. So now you have a breach of duty. And now you have, that falls under nonfeasance. So now what do we have? We have the three things against us, right? So now we could be held liable. To be held, you have to have your duty, standard of care, and your breach of duty. Does that help, Brian?
Yes, thank you.
Yes, and those are important to know. So read over the rest of that on page 69 and 70.
I read them. I just put different words in in the spots for them because I didn't know how to pronounce them.
Pronounce them, yeah. All right, so today's the 29th. It is. Today's the 29th. And so your first lab class is tomorrow, which is Wednesday. And that's the one in Perquimans. Does anybody have any more questions? Go ahead.
Or is it 6 to 10?
I think this one, the first one, is a 3-hour lab because I think that there's not a module exam.
Where are we meeting inside the building at?
So it should be in, I don't know if anybody's familiar with Perquimans, emergency services, but there's 2 entrants, and I believe that it is in the training room. So when you come up to Perquimans Emergency Services, you'll see the sign. If you go past that sign and park what we call by the water department, that's the back entrance right where the classroom will be held. If you park in the front, it's no big deal. You just got to walk through the maze to get to it. Trying to pull the syllabus back up.
Is there a code to get in the door, or will somebody let us in?
Yeah, there. When you get there, there's a phone to pick up, and you can ask them to let you in because it is locked. All right, so next week, let me see. All right, next week we have our medical terminology and human body systems. Human body systems is usually a very extensive chapter to go over. A lot of words to know. It'll go over like your body plane systems. It'll go over your abdominal quadrants. It'll go over your cardiac muscle, smooth muscle, go over your pathophysiology of your lungs, the blood flow of the heart. This is when we start getting into more of the detailed information and not just the review information like the first 6 chapters have been. So familiarizing yourself with those terms prior to us going to class will definitely help you. Is anybody doing the review questions in the back of your chapters?
Yes.
Okay, are those helping you?
Yeah.
I haven't done the first one.
So would you, at the beginning of your chapters, if you'll look, you'll see what's called learning objectives. I'm not saying don't read your book, but I'm saying these objectives are definitely the main points that you need to know. So when you're reading over your book, make sure you look at those objectives and you are specifying and specifically knowing what those are and what they mean. So those are definitely the questions that when you read over your material and you don't understand something, let us know and be like, hey, objective 8.1, I don't, really understand. So next week we have our medical terminology, our human body systems, and then you have your first module exam at your lab that you're going to for that module 2. It's your module 1 exam. And then we'll also cover chapters 9 and chapter 10 as well. So that week will be a pretty busy week. Your first module exam, you're going to kind of figure out what the questions are going to be like. But I think everybody's doing pretty well on their quizzes, so you shouldn't worry. All of these are pulled from the book. Does anybody have any questions or concerns? No?
Is the module exam, are those questions going to be pulled from the quizzes, or are they going to be pulled from the book?
So the ones that are pulled that you have in your quizzes all come from a test bank that come from the book. So I would think that they wouldn't be the same questions, but they would come from the same test bank.
Is it all closed book?
Yep, they're proctored. Those module exams will be done in front of us, so we'll watch you and you'll do them on computers. So yes, closed book.
And those you have to make a 70 on in order to keep going, right?
I believe that they've changed the way that the grading process works. I think it's as long as your overall grade average is a 70. But I believe that every module exam you do have the chance to retake at least once if you would like to, if you don't make a grade high enough that you would like to. And I highly encourage that, because the deeper we get into the book, the harder these exams will get. It's just more in-depth information. You're going to have things like medications, rhythms, different diagnoses. So just make sure that you're staying caught up and your GPA is high enough at the beginning. Does anybody have any questions? I feel like I keep asking that. All right, if not, feel free to message me. I don't know if you have my phone number. I can put it up here. This is my phone number. Please do not call me, text me, because if I don't have your number, I will not answer it. But if you text me and you need anything and you need me to call you, let me know. Oh, I just sent that to Callie, not everybody. Same thing as Cliff said, if you need anything, feel free to reach out, but don't call me at 3 a.m. All right, y'all, if you have any questions, just let me know, and I will see most of y'all maybe Wednesday. All right, have a good one.
You too. Thank you.
Bye.